This meeting is now being recorded.
Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview to those that are attending our free program for the first time. So we will go over who we are, what is our program, some upcoming events. We'll then introduce Dr. Das. We'll have a Q&A session, and then we'll be concluding our session this evening. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008. The same year, my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 65 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and where possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
Coming events include our webinar coming up next, the end of this month, December 17th at 7:30 p.m. The presenter will be Dr. Peter Byers. Dr. Byers is the Director of Collagen Diagnostic Laboratory at University of Washington. His lab is the primary source of diagnostic testing for EDS, and his topic is going to be about vascular EDS. Just wanted to note that in 2015, the webinars will move to the first and third Tuesdays of each month, continuing to occur at 7:30 p.m. Eastern Time. For those of you attending live, there will be an opportunity for Q&A after this presentation. Please add your questions at any time by clicking the Q&A icon at the top of your screen. After typing a question, click the orange button to submit. Our speaker tonight is Dr. Das. He's an otolaryngologist, which is an ENT, ear, nose, and throat doctor. He will discuss Sinus Care and Ehlers-Danlos Syndrome. Dr. Das is the CEO and Medical Director at the new U.S. Institute for Advanced Sinus Care and Research, located in Columbus, Ohio. He also serves as the Executive VP and Chair of the Scientific Advisory Board for ENT Vantage DX which is located in Austin, Texas. His previous roles include Director of the Division of Rhinology Sinus Surgery at The Ohio State University, Assistant Professor at Medical College of Georgia, and he is U.S. Board Certified otolaryngologist and a Fellow of the American College of Surgeons and American Rhinologic Society, as well as a research associate at the Center for Microbial Pathogenesis at Nationwide Children's Hospital in Columbus. Dr. Das has been recognized as one of America's best doctors and best sinus surgeons. His NIH-funded research was awarded the 2013 Fowler Award regarding his work on detecting the cause of sinus infections. So with that, I'm very pleased to announce and welcome Dr. Das. We're looking forward to your presentation, and I'm going to go ahead and turn over the microphone to you now.
Okay, thank you very much. First just wanted to start by thanking the leaders of the society for the very kind invitation to talk to you guys today. And I'll tell you a little bit of my life story, which has made me somewhat interested. But I recently have switched from being the director of sinus surgery at The Ohio State University to trying to create an institute to take care of people with really advanced sinus problems and rare sinus problems. And this has now been going on for about a year or so. What I've really learned is that for people with rare and advanced problems, the vast majority of outstanding health care that's being delivered through them is coming through societies such as the EDS Society. And it really goes to show the power of networking and the web, frankly, on communicating and sharing and disseminating knowledge. And it's really societies like this that have provided so much benefit to people to get them to the right places, to provide support, to let people know they're not alone in their fight in some rare disease. And so I just really want to congratulate you guys all. It was really somewhat kind of chance that I found your society, but it's really due to the efforts of you guys and your predecessors in creating these kinds of societies that has really led to this. So with that, I thought I would start by introducing myself. My name is Shu Das. I was born to parents who immigrated from India, and I was born in Atlanta, Georgia. And originally remember the first medical problem that I had was that I was born with flat feet. And so since then, I've always been my joints have been I wouldn't say hypermobile to the level of a type 3 EDS patient, but I was somewhat more flexible, which actually as a kid was somewhat of an advantage. I was very fast as a sprinter, and I was a pretty good athlete. But when I was 5, I cut myself on a dining room table, just playing with our friends, and I ran into the corner of the table and had to go to the emergency room, got stitches, and developed a very flat, hypertrophic scar on my face that was, very disfiguring as a kid, but have always been interested as to why, I developed such a bad scar. And so then, then playing baseball in high school, I was a pretty good baseball player. Again, I had very fast bat speed, and I could swing very quickly for my age. That was what was somewhat unusual. But then sliding into second base in high school, I dislocated subluxed my shoulder. And since then, my shoulder has never really healed very well, where I would sometimes when I'd sleep would sublux my shoulder and just have very severe pain, and continue to have shoulder problems to the point where in college I kind of stopped playing basketball because I would risk subluxing my shoulder too much. So then I ended up, well, also this is a side, I in high school got hit by a baseball where I broke my nose and it affected my sinuses. So I also developed pretty severe sinus problems. I think that's unrelated to EDS, but well, frankly, it might not be unrelated to EDS, but I'm as a result got an interest in sinus infections even before med school, starting in college. But the experience of going through the medical system then and seeing how I was, treated and how, doctors really don't have all the answers. We kind of follow what we think we know. We're very certain about what we tell our patients, but if you are somebody who falls off the spectrum of what is common, you're sometimes alienated and ostracized by the medical society. And so I kind of got that sense, that my sinus problems didn't really add up fully to the kinds of surgeries I had. And so I became very passionate about sinus disease. As a result, I think it really helped me be a better medical student. I, really loved medicine. I ended up doing very well in medical school, or very well in college. I got a full merit scholarship to go to the University of Virginia, and then was the president of my class, and did very well in medical school. So I was fortunate. I got picked to go to one of the top ENT programs and trained under some of the best sinus surgeons. And really, somewhat kind of forgot about EDS, but then got lucky to be put into an epithelial research lab with one of the top cystic fibrosis doctors, Richard Boucher. And so there I learned a lot about microbiology, its role in, your epithelium and protecting against infections, and, have kind of devoted my career to the research of what causes bacterial infections on basically on the surface of skin. And so now that has come full circle in that, I would also see people as I started practicing who had skin disorders, and just lucky because of my background and my interest in reading about EDS when I was in medical school. Again, like many of you, I thought I was the only person on the planet who had EDS, but then also learning about bacterial infections, I was able to kind of put those two together, and as a result, have been able to help a lot of people with connective tissue disorders. So that's kind of my background. I'm preparing for this lecture, and in the last couple of years have, come to realize I haven't been formally tested, but I'm pretty sure I have type 1 EDS. I have very, very elastic skin, but not cutis laxa, where it, stays tented. My skin stretches and comes right back to its position, and all of my symptoms are very similar to many of the symptoms that people with EDS have. So, after joining this society, I also hope to spend more time learning about it, and really, I was telling John, I hope to be a powerful resource for people with EDS, in that my family, I'm lucky, my wife's uncle was the dean at Johns Hopkins Medical School. Another uncle is the chairman of anesthesia at Johns Hopkins, and people with EDS don't do well with local anesthetics. But I am very well connected in the medical community throughout the U.S. And so my hope is to really try to harness awareness and try to marshal resources so that we can have the NIH spend more money in trying to direct better therapies and cures for patients with EDS, and something I'm looking forward to devoting a significant portion of my future career towards. So sorry, I'm somewhat long-winded, but that's kind of my intro. I'm just really excited to talk to you guys, so I apologize for spending a little too much time on that. But to start, I first wanted to talk a little bit about your just basic sinus anatomy and how what is acute sinusitis, and just kind of get everybody up to speed on sinus disease. So, oops, sorry, I just now closed my slide deck. So, your sinuses are Can everybody hear me? I apologize. I clicked out of this deck, and so I can't tell now if you guys can
yes,
hear me
we
or
can
not.
hear you.
Okay,
we
great.
can hear you fine. So.
Okay, great. Okay, sorry about that. So
No problem.
Now my slides are reloading. But anyway, your sinuses are these spaces in your head. We have 4 groups of major sinuses called your maxillary sinuses, your ethmoid sinuses, your frontal sinuses, and your sphenoid sinuses. And they are basically air spaces around your head that we're not sure why we have them, but they basically can cause pockets of infection. So the thought was, there was a dinosaur that was found to have sinuses, and it thought that it changes our voice resonant frequency, so our voices travel further than others, so we can speak and communicate a little bit better. Some people have thought sinuses allowed people to evolve out of the ocean or primates to walk on 2 legs because our head skulls became a lot lighter. And but basically, nobody really understands why we have sinuses. I think they're reservoirs for infection. And so the groups of sinuses, you have these pockets of open areas underneath your eyes. There's your maxillary sinuses. In between your eyes are your ethmoid sinuses. Above your eyes, like right in your forehead, are your frontal sinuses, and very deep in the center of your skull, which are your sphenoid sinuses. So now, John, my slide deck is unfortunately still just spinning that it's loading. So can you reset my slide deck at all, or should I close out and try to load this again? Oh, okay, there we go. You can keep moving. So these are your maxillary sinuses. These are MRIs that show, when we're born, you don't very have much of a sinus. So this is actually important. A lot of children between the ages of 1 and 4, if you're going to get an infection, they mostly present as ear infections because you don't have a lot of sinus space. But as we get older, from 6 and now at 16, we're fully developed, your sinus space, this black area, becomes a potential reservoir for infection. So adults often get more sinus infections than children. And so next slide, John, I don't know if, so yeah, these are your ethmoid sinuses. So now these are between your eyes, and they continue to expand. You do have ethmoid sinuses at birth, but they continue to expand into larger spaces. Next slide. Your frontal sinuses are over your eyes, and they're typically not born with those. As you can see, the 1-week-old has no black airspace above his eyes, but as you get older, these air spaces get larger. And so there is some truth to the statement that the older you get, the more air in your head you develop. And so that is true and continues to happen. So next slide. Oh yeah, I'm sorry, your sphenoid sinuses. So sphenoid sinusitis also, if people get sphenoid infections, which are way in the back behind your eyes, they manifest as a pain on the top of your head or in the back of your head. And so if you've had weird headaches that aren't migraines, but, follow a cold where you're having weird pains behind your eyes or on the top of your head or on the side of your head, you might be having a sphenoid infection. So next slide. So when we think about sinus infections, we categorize them into 2 types, acute sinusitis, or in the American Rhinologic Society, we call it acute rhinosinusitis, rhino meaning nose, and sinus, being the sinuses, but it points that both your nose and your sinuses are affected. And they're very common. Most people get about 6 to 8 upper respiratory infections or a common cold a year. Most of the vast majority of those are caused by viruses. About 60% are caused by the RSV virus. The rhinovirus, but RSV and influenza can also cause more severe viral infections. And then about 10 to 15% of the time after a viral infection, you'll develop a bacterial infection. So next slide. This was Jack Gwaltney, who did a bunch of research in the 1960s, but this is a great slide that lets you know how a typical viral sinus infection or viral cold should progress. So in the first couple days, you have a little bit of a fever and a headache. That fever typically drops off quickly after the first 4 days, and your headache also improves. But later in the cold, your nasal discharge kind of takes a lot longer, about 2 weeks to fully go away. And the cough from a cold really persists. So the cough is the last thing that goes away, even after your fever is gone. So you might have a cough that lasts for several weeks after you develop a viral infection. So next slide. So the thing we worry about more is if you develop a bacterial sinus infection, and we'll talk about this a little bit more with EDS. The bacteria, typically in a sinus infection, we have bacteria that don't cause any problems and live in the back of our throat, in our nasopharynx. So viruses don't have enough DNA to have an escape plan out of your body. So what they do is they come into our nose and they start replicating quietly. They turn off the immune system so they can continue to replicate. But what they do is they upregulate a receptor that lets bacteria that normally are causing no problems in the back of your throat start to grow and enter a space that they don't belong. And so over the next several days, these bacteria move from the back of your throat to your ears when you're a kid, or into your sinuses as we're an adult, and then your body recognizes the bacteria as being in a place that they don't belong. So then about 3 to 4 days later, in trying to kill the bacteria, they also detect the virus, but they stop the mucociliary flow, and your mucus gets really thick. You start sneezing, you start blowing your nose, but it's really the bacteria that set off your body's reaction to help the virus get out of your body and then spread to other people. So that's why we tend to develop bacterial infections several days later. Or you can go to the next slide. But those are the things we worry about, because if you have a gas-forming bacteria like this kid I operated on, you can see all the swelling on the side of the kid's head, all the gray stuff. And so this kid I had to take emergently to the operating room. You can see on the other side, this poor girl's eye was bulging out of her head. And then when we opened her sinus, we got a bunch of pus that was growing in her frontal sinus. So this was a life-threatening emergency. And you can see, sinus infections can unfortunately be sometimes very severe. So next slide. So that's an acute sinus infection, which, is very common. 1 in 7 people have. But what is more important for EDS patients is what we call chronic sinusitis. So people who have sinus infections that either one infection lasts more than 90 days. So for 3 months, people are feeling sick. It's typically in the winter when everyone is just feeling like they are constantly sick, and they just live with it and they stop complaining about it because their face hurts and they are constantly coughing and having postnasal drainage, but nothing seems to help, so they kind of just ignore it. Or it can be people who have frequent infections, like 3 in 6 months or 4 in a year, who have what we call recurrent acute rhinosinusitis, which is another form of chronic sinusitis. So, and for these people, the thought is that they have some problem in clearing the bacteria that is in their sinuses. So it can either be, a problem with their immune system, or it can be, some type of bacteria that forms a biofilm that's really difficult. But for For Ehlers-Danlos syndrome, the problem that I'm pretty convinced of is by not having properly organized collagen fibrils in your basement membrane, it makes it difficult for our white blood cells to respond to bacteria when they penetrate the first defense of our skin lining. So our immune system has three different aspects. One, we have the cells that line our sinuses, which are protected by, they have cilia on top of them, so they are constantly brushing a mucociliary blanket of, very thin mucus. So it has two layers. On the bottom is some salt water, and on the top is these mucus proteins, which are these sugary proteins that form a blanket over our cells, and the cilia are constantly brushing this blanket, producing the blanket and then brushing the blanket down the back of our throat into our stomach. So any bacteria that land in our sinuses are brushed away down the back of our throat into our stomach. Our stomach acid kills the bacteria, and we then look at the bacterial pieces, and our immune system develops antibodies against particular bacteria. And so that protects the vast majority of people. Now, occasionally, bacteria get through this mucociliary blanket, and they get exposed to the level of our cells. And so when that happens, they activate these things called toll-like receptors on our cells that let our body know, hey, a bacteria has gotten too low. It's penetrated our first line of defense. And so then those cells will produce different chemicals called cytokines like IL-8, IL-6 that signal the body to say, hey, we've got a problem here. We need some help. And so often there are helper, attack cells, white blood cells that are in the tissue level that if they're local, they'll be like, I got it, and they take this bacteria, they swallow it, and they kill the bacteria. But in a lot of folks, what happens is these signals go into our bloodstream. Our bloodstream gets these signals, and they go, okay, we'll send some help. And so then they send white blood cells from our bloodstream, which leave the bloodstream. They squeeze through the collagen fibrils, and they follow these fibrils down through the bloodstream into our subdermis, up to the dermis, up to the epithelial level, where they kill these bacteria. So the problem with EDS and why EDS, in fact, the arthritis of EDS I would not be surprised if we find out that most of it is due to a bacterial problem and a problem with clearing bacteria that leads to a lot of inflammation in our bodies and a lot of the pain and such caused with joint problems, is that as bacteria initially get into our blood to pass the first line of defense, there is problems that oh great, thank you. I can work my slides again. There is the problem that our white blood cells have a tough time getting to the area that they need to because our collagen fibrils are disorganized somewhat. So the white blood cells are, it's like the highway system isn't made with interstates. It's made with, winding roads all over the place. And so in the time that, somebody without EDS, their white blood cells could get to the area quickly. People with EDS, our white blood cells take a while, so these bacteria now have the ability to divide and kind of create a barracks a little bit and get into areas that are a little bit more infested, so that by the time our white blood cells do get there, they get really irritated and angry. They're like, oh my God, this isn't just one bacteria, this is like now 10, so bring the entire army. And so, for example, now with joints, what I think is happening is people are brushing, when we brush our teeth, another problem with EDS is our gums, the collagen fibers don't adhere very tightly to our teeth. So there's spaces for, particularly when you brush your teeth, for bacteria to translocate into our bloodstream. As they get into our bloodstream, they often find their ways onto plaques in our arteries, or they find their way into joints or tiny spaces in our spinal cord and in our backs, and they're, again, rapidly killed because our white blood cells can get to where they are quickly and attack them before they find a film. What probably is happening in EDS is these bacteria are getting to our joints, or our the linings of our arteries, or our mitral valves, or whatnot, distal joints, and then they are able to form a biofilm that's a little bit thicker. So then our immune system has to work a little harder and starts destroying our tissue, and so we get the nodules or arthritis or different problems because that bacteria was there, and our body is now having to, use stronger weapons to kind of destroy that tissue, and so our body ends up inadvertently destroying our own tissue as well. So, so that is, my thoughts on the etiology of what's going on with Ehlers-Danlos syndrome. But frankly, I've never been able to prove this, because I've not been able to study a lot of folks or to look at that. This has really just been, me putting thoughts together based on what I've learned about, different diseases and kind of everything. So, unfortunately, my life is about evidence-based medicine and publishing data and doing good randomized controlled trials. Frankly, with a rare disease, that's much harder, so you kind of have to go on gut instinct and such, but this to me makes the most sense into what I think is going on with EDS. And so I've gotten some questions that are a little bit more specific for patient-related questions, so I'll address those at the end. But I'll take a break here. Either if anyone wants to ask me a question in the chat or on the question. Does anybody have any questions on the definition of sinusitis, like acute sinusitis or chronic sinusitis, or any general questions about sinusitis? I will maybe answer some of those here. Okay. Well, if you do, please don't hesitate to interrupt me. I hate giving formal lectures. I love just having a conversation with people. As much as we can do that on this webinar, I'm happy to do so. So just feel free to interrupt and ask anytime for anything. Okay. So now moving on. So the treatment for chronic sinusitis. So conventionally, acute sinusitis, we typically tend to ignore the viral infections because we don't really have good antiviral therapies. And again, it's very difficult to pick up on the symptoms of viral infections on the first couple of days for URIs. I mean, in fact, it's very similar to what happened with the Ebola infections. Like, if you can detect it early, then we could apply antiviral therapies that could potentially help people and prevent the virus from replicating, causing a lot of damage. But by the time the viruses have caused a lot of replication and your immune system's already attacking, there's not much we can do. So that's the problem we have with viral infections in general. So for acute viral sinusitis, there's not much that is worth doing. Now, and for most people, and I don't think this is as related to EDS patients, but for most folks, the 1 in 7 who have acute bacterial sinusitis, which is about 10-15% that go on to where 3 different types of bacteria make 90% of it, strep pneumo, Haemophilus influenza, or Moraxella, they end up creating a concentration of bacteria that cause problems. For those patients, we tend to recommend antibiotics. And for most people, I don't think this represents most EDS folks, but amoxicillin is enough to kill, enough of that bacteria so our immune system can mop up the rest. And if your kid is in a daycare or you're or your doctor, you're exposed to a lot of resistant bacteria, sometimes we use augmentin, which is a little bit more of a broad spectrum antibiotic that it contains a chemical that helps overcome amoxicillin resistance to help kill some of those bacteria. But for most non-EDS patients, I would take like a week or so, or 3 to 7 days, and that would clear their sinus infection. Now, for people with chronic sinusitis, now I added this slide too, just for everyone to know. So, I'll tell you when I think there are really important take-home pearls from what I'm talking about that you should really remember. So this is one of them. If any of you guys ever develop a sinus infection where your face swells, if you have, let's say, eye swelling or your cheek is swelling or redness of your face from a sinus infection, that can become an emergency, where that means the bacteria has spread out of your sinuses and can potentially leave your sinuses and cause problems like go into your brain or into your eye. So that is an emergency that you should immediately go to the emergency room or see a doctor, but you need therapy within hours of that happening, not within days. So any facial swelling or redness or any actual physical changes to your face, that's an emergency from a sinus infection. So next I'm going to answer a couple of questions that people have written about kind of the treatment of sinus infection. So one person was asking about getting fullness in your ears and feeling like they're underwater and kind of having some popping and gurgling. That is often related to sinus problems. It's a problem called eustachian tube dysfunction. So we have these tubes that connect the back of our sinuses to our ears that equalize the pressure behind our eardrum. So our eardrum, for it to work well as a drum, needs to have a pocket of air behind it and the pocket of air in front of it so the drum works really well. The problem with the pocket of air behind it is air is 20% oxygen, and so the cells in our lining absorb the oxygen and they make it into carbon dioxide that leaves in our bloodstream. So it creates a vacuum over time that would, suck everything up and suck your eardrum. And so we need a tube that connects the back pocket of air into so we can restore the air basically every once in a while. We do that without thinking about it when we swallow. We sometimes clear our eustachian tubes and kind of clear the pocket of air. So unfortunately though, if you have sinus problems, it causes all of our tissue to swell in our nose, including our eustachian tubes. And by doing that, our eustachian tubes don't clear air well. So what happens is you create a vacuum into your ears, and you get sometimes a little bit of fluid that fills your ears. When you get fluid that's within your hearing bones, it can then make you feel like you're underwater. And as that fluid moves around, you get this popping and gurgling, and so that can be very much due to chronic sinus problems. So another question was, I'm allergic to penicillin. What else can you use for the first-line infection? And now again, I'll get to this. I don't think EDS patients, unfortunately, follow typical sinus guidelines, but you can use drugs like doxycycline or clarithromycin, which are reasonable first-line agents. More powerful drugs for sinus infections are like fluoroquinolones like Levaquin and Avelox. They're not great for EDS patients too because they cause a lot of collagen problems. They cause a lot of tendinopathies and and so frankly, those aren't drugs that I would be comfortable risking in EDS patients unless they were very sick. So probably for EDS patients, I like clindamycin as my top choice of antibiotic. The problem with clindamycin is it can cause some bad diarrhea, and it can cause a particularly bad diarrhea if a bad type of bacteria come in. So I use it rather sparingly. I just have patients. Sometimes I use Augmentin, but the biggest thing with EDS patients is they need much longer courses of antibiotics than most people are giving them. Typically, over 2 weeks, sometimes 2 to 4 weeks, to fully clear infections and clear the films that EDS patients get so that they don't get into this recurrent problem. So another patient asks, I cannot take most antibiotics, but I've had to take Levaquin 7 to 9 times a year. Is there a better long-term treatment so I don't have to take such a strong antibiotic? It's a great question. Levaquin is a fluoroquinolone, and the problem with fluoroquinolones is that they can cause problems in your tendons, and they can really soften your tendons. And as you know, for EDS patients, that's already an issue. So being on Levaquin is not a great choice. So for somebody who's had 7 to 9 kind of infections a year, that's somebody I would consider minimally invasive surgery on to kind of open up their sinuses, primarily so that if you then develop an infection, you can irrigate with topical antibiotics that can kill the bacteria directly and not require you to have so many antibiotics that you take systemically, which could be hurting our tendons. So another question was on the relationship between strep throat, chronic strep throat, and EDS, and it was the accumulation of bacteria and how well people handle tonsillectomy and or tonsil is common with people with EDS. And basically that whole issue. That's a great question. It's along the same line. So the problem with recurrent acute otitis media, so ear infections when you're between the ages of 1 to 4, strep throat, chronic strep throat, between, when most people are in high school and college, and then sinus infections when you're older, I think have to do with similar things. Now, group A strep is a problem that can be avoided if you never were exposed to group A strep, but a lot of people are. But then the problem with group A strep is that once you get it, you never really lose it. It stays in your system forever. And if it's less than about 1 to 2% of the bacteria in your throat, you don't really get problems. But if you then get a problem where your immune system, like you get a virus that lets your bacteria propagate, or frankly for strep throat too, where group A strep, we're finding alcohol might affect it, but something causes the group A strep to grow. And because we never can fully get rid of group A strep, you can become a strep carrier and constantly have to deal with it. And removing your adenoids and removing your tonsils are very helpful for people with group A strep and group A strep carriers. Unfortunately, it's a very painful operation to do once you're a teenager. It's much better if that were done in children. So children with EDS, frankly, I would probably be more aggressive in having their tonsils and adenoids out earlier than I would at an older age, because EDS patients, I think, and this is another point, I think much of the problems we suffer from in terms of joint pain are due to chronic bacterial microinfections of our joints. So removing areas that bacteria can harbor themselves, which are our tonsils and adenoids, I think are very helpful to EDS patients and sinus cavities as well. So I've become less of a proponent to argue for surgery for removing tonsils and adenoids and otherwise healthy children, but for people with EDS, I would personally be more aggressive in having our children's tonsils and adenoids out. And so, fortunately, I don't think my 2 sons have the type 1 EDS that I think I have, but at least for my older one, we've had his tonsils and adenoids out. So I'll answer this question quickly. So also your adenoids in most people on their own naturally go away by the time you're about 18 or 20. And so most people, once you're over 20, don't have any adenoid tissue left. And so people who have their tonsils removed as an adult, it's very rare that, it's typically unethical surgeons who are saying, well, we're going to remove your adenoids when in fact you don't really have any adenoids left. And also your tonsils, for the most part, by the time we're in our mid-40s, most of our tonsil tissue is gone as well. In terms of tonsilloliths, which are tonsil stones, which are basically trapped bacteria that get trapped in the crevices of our tonsil, which might be the purpose of our tonsils, frankly, to be able to sample those bacteria to help our immune system develop. I don't know if they are more common in EDS patients. Frankly, I have not heard of that nor read that, but frankly, I have not seen enough EDS patients to be able to get my own feelings on what's more common in terms of ENT problems with them. But they're just a very common problem in general. Speaking of it, I get bad tonsil stones, and I take these little wooden shish kebab skewers that my wife uses to make shish kebabs, and I use my iPhone flashlight and shine it into a mirror and then carefully push those stones out. Not necessarily because you need to, but they just drive me crazy. So, and then another question was chronic postnasal drip that sinuses cause. Is there a correlation with reflux? And there was a question earlier that I was saving on a patient who has very bad reflux and chronic throat clearing. Chronic postnasal drainage is a problem of chronic sinusitis. If your body has a film of bacteria that is lining your sinuses and none of the army is coming to clear it, your body makes more mucus to try to wash that away, and so it manifests as a chronic postnasal drip. So people who have suffered for chronic postnasal drip for a long time, I would say 2/3 of those people have what's called laryngopharyngeal reflux, where the stomach acid, it's not causing heartburn, but as the stomach acid deposits in the back of your throat when you sleep, the back of your throat swells, and then all day long you're constantly clearing your throat to try to get rid of that sensation, but it's really the swelling of your arytenoids pushing on your esophagus, and so most of that is due to uncontrolled reflux. About 1/3 of that is due to chronic sinuses, where you're just got a chronic postnasal drip. Those patients often feel worse when they go to sleep at night. Right when they sleep, they feel like they're drowning, and they can't sleep that well because as they lie flat, they drain a lot. So postnasal drainage can definitely be a part of chronic sinusitis, but it's more often a part of what is called silent reflux or laryngopharyngeal reflux, where reflux is causing problems in your throat and not heartburn. So another question, what about orange tan colored discharge? Yeah, that if it's coming out of your nose, could often be due to a particular type of bacteria called Staph aureus, often causes this orange colored discharge. So it could be to a chronic bacterial problem. Another patient saying, I'm not able to clear my ears. That's similar to, and they feel like they're vacuum locked. That's exactly, if the back of your throat is swelling so that your eustachian tubes get blocked, that's a problem. Is called eustachian tube dysfunction. If it's that severe where you can't clear your ears at all, then sometimes you can put a little tube in your eardrum as an adult, and that helps with that problem. Another question that's saying, I have no frontal sinuses. Does that affect the issues I have? That could be a blessing and a curse. Having no frontal sinus often protects you from developing, bacterial infections that can enter in your sinuses, and many people, a small percentage of the population don't have frontal sinuses that develop. Yeah, but the curse part is the reason they're not developing is possibly because the frontal recesses are blocked with bacteria. And so that is people with cystic fibrosis, for example, don't often develop their frontal sinuses very much. So it could be somebody who has chronic sinusitis that doesn't develop frontal sinuses. Another question is surgery a high risk with EDS patients? I don't know that question, honestly. I know EDS patients have a tougher time with local anesthetics, and so it's tough for them to get numb. And so they feel often sometimes have pain at surgery. When I had my sinus surgery, when I woke up, I was in very severe pain, but I didn't necessarily have more complications during surgery per se. No, I'm not sure if I've ever operated on an EDS patient, to be honest. I've heard that. I don't understand why surgery would be a high, vascular EDS definitely, I think, is your blood pressures could fluctuate. You could run the risk of adding more shear stress to your blood vessels during surgery. But frankly, I think surgery is probably beneficial in EDS patients in that if you can get rid of the reservoirs of bacteria out of your system, I think you are going to look at delaying osteoarthritis and joint problems for a longer time, because to me, frankly, there's no reason why our joints shouldn't heal well after, a hypermobility, or an extension injury. Otherwise, typically, especially when you're young, that shouldn't lead to necessarily a severe osteoarthritis. So I am more in the family of thinking osteoarthritis is not as much a degenerative problem as it is an inflammatory problem. But there obviously could be some degenerative problems that occur. But so I think one of the problems with surgery is there's a risk that bacteria stream into your bloodstream at a higher rate during surgery. And so anyone who has surgery with EDS, I would just recommend even bringing up or even frankly demanding that you get placed on preoperative antibiotics during your surgery. So any special considerations for EDS surgery, EDS children during surgery, anesthesia healing? Yes, that's a great question. So like with me and kind of the hypertrophic scarring, if your child is having surgery and requires stitches, like for a broken arm or a cut on their body, everyone with EDS should, one, request a plastic surgeon to repair your anything that needs stitches, and to do multiple deep layer stitches and have almost no tension at all on your epithelial layer, because EDS folks are more prone to hypertrophic scarring, and plastic surgeons understand how to remove forces on the skin. But mention that to anybody. Say, hey, I have EDS, which means we scar much worse, so there can't be any tension at all on any of my sutures, and that might help with the cosmesis. And then outside of that, anything that requires local anesthesia, and this frankly, I do not understand why this occurs. And I'm considered an expert on anesthetic problems in sinuses, for example, but I do not know why people with EDS don't really respond well to local anesthetics, but I do know that as a case. So if you're having just a knee block or something on where people just use a lot of local anesthesia to do surgery, you need to be careful that the local anesthesia is not going to work. And so that's another risk in children who have surgery. But general anesthesia, I frankly haven't seen any problems. And frankly, like I said, I would recommend getting tonsils and adenoids out in EDS children earlier than later. And then, let's see, needed tube inserted to be able to clear my ears. How do I find a good doctor? That's a great question. How do you find a good doctor, a good surgeon in general? One thing I think all of you guys are probably aware of by just having a rare problem is that, in medicine we're taught to create this facade that we know everything, and there's only one answer, and we basically know it, and then when we say it, that's the truth, and you wouldn't even think to question it because that's just, what it is. And the field of medicine has all these words like, erythema instead of saying red, or sinusitis. Itis just means inflammation. And so the problem with finding a good surgeon is that there's a huge spectrum of quality in surgeons. There are there are people who, I would say 3 to 5% of doctors who become jaded and just see people as a way to make money, and so they're trying to find problems with people so they can find the right surgery, and they just recommend a surgery. And if you don't, I mean, they're really have just have forgotten about caring about people. And that, I would say 90% of surgeons, if you are lucky and you have a common problem that they understand and they're comfortable with, they do a very good job in managing that and give you good advice. Then if you're lucky and that problem doesn't require a high-quality surgeon, then it really doesn't matter who the surgeon you are. But unfortunately, if you're a person with a rare problem, you're a threat to most doctors, because doctors just do not know how to say, look, I don't know what is going on with you. I have no idea, and, frankly, I apologize. I can't help you because I just don't know. I mean, that, I feel like I'm one of the few doctors who was secure enough to be able to do that because I have a rare problem, and I realize that doctors don't have the answer. And frankly, that's been empowering for me, and I think has made me a better doctor. But that I can tell you, I am unique in that most doctors would not ever say that to a patient. So now, so the point of me saying that is you guys need to shop for surgeons, and the way to do it, I recommend, is to go about it just like you're trying to buy a car. So for somebody, if my child needed surgery or I needed surgery, I would, at a minimum, get 2 or 3 opinions from, who I would Google and who is the best doctor in my area, and I would go to all 3 of those doctors. Ask hard questions. If anyone is getting offended by you asking difficult questions, you need to just say, okay, thank you, and leave politely, but you need to leave. Anyone who is insecure to the point that they're being threatened by you asking difficult questions like how many of these you've done, what's your complication rate, are you the best in this area, this is my son, I'm putting my utmost confidence in your hands and I'm putting them to sleep, those are very valid worries to have. And so the good surgeons will be like, yes, I totally agree. Yes, here, this is, if I were going to give you a second opinion, go to this doctor. And then if you hear 2 stories and you feel 90% is the same, but they're disagreeing on the 10%, then you go back to the one you really liked and you ask questions about those issues. So, to shop for a surgeon, you need to go to several doctors. Now, the question somebody asked, I needed tubes inserted to clear my ears. Fortunately, that is one of the easiest things we do. And so, frankly, the quality or skill of the doctor that you see is not very important. So you can, frankly, go to any ENT, and they'll be able to put a set of tubes in your ears without much difficulty. Sinus surgery, on the other hand, is very technically dependent on skill. So if you go to see a sinus surgeon, you need to go to somebody who ideally does a lot of sinus surgery and is, I'm biased, but I would prefer that people go to a rhinologist as opposed to a general ENT, because that's all they do is sinus surgery, and they're much better. Sinus surgery is one of the riskiest surgeries in ENT. And so there are different operations where the surgical skill of the doctor you go to is very important. It's no way the public would know, frankly, but the ones where the skill is important, it's very important you find a good surgeon. So another question: connection between sinusitis and occipital or trigeminal neuralgia pain. That is a great question. I have occipital neuralgia. And so my C3 nerve root that comes out of my right neck, I think it's impinged in my spinal cord. I think EDS patients sometimes have hypermobile joints, but for whatever reason, my nerve is there. And, frankly, whenever I travel a lot and I sleep in a hotel, or if I drink a lot, my occipital neuralgia flares up really badly. And so I think that is probably related to EDS, in that if my neck is maybe a little bit more hypermobile, you're more likely to get occipital neuralgia. Now, trigeminal neuralgia I don't have. I know a lot of people with EDS have reported a lot of TMJ dysfunction, but frankly, I think TMJ dysfunction might be a little bit more outside of a joint laxity problem and more due to like bruxism, people who grind their teeth, and have asymmetric bites. But, I have seen and reading that people with EDS have more often have TMJ problems. So I think, again, that might be a joint dysfunction-related issue. There's a new therapy for TMJ that's just come out. It's called TMJ Next Generation. You guys can Google that, but I've been very impressed with it. They're basically all these ear inserts. They put pressure on your possibly on your TMJ. I'm not sure why it works. I haven't heard a good reason, but I've been seeing a lot of success with these TMJ ear inserts for the treatment of TMJ. So I don't know why people get trigeminal neuralgia with EDS. I don't really understand even the TMJ, but I've read that that's more common. But occipital neuralgia, I do understand. I personally have, and I feel it's probably due to joint laxity at your C3, between your C2 and C3 vertebra. And I would not be surprised if occipital neuralgia is common in EDS patients. So, all right. Well, next question. So my son had the flu and had a bunch of ear infections and antibiotics and was sick for 6 months. I'm sorry to hear that. My 13-year-old son, after antibiotics at age 15, he's had a lot of pain and he's been down for 3.5 months. Could this be related to EDS? Is it how he's very long after antibiotics? Yes, I think unfortunately this could be related to EDS. It could be related to several things. One, the antibiotics that were used were potentially fluoroquinolones and were further damaging to tendons in his body, or two, that he's just unfortunately had a chronic ear infection that never has cleared with several short courses of antibiotics. And so, it's possible. As a part of my license, I can't give people personal medical recommendations over a website without talking to patients. We do offer a kind of a telemedicine consult where people can just call our office and we charge $150 for half an hour, and we can give directed advice for people who live outside of Ohio. And for people who can come to our office, you could have a regular visit that insurance pays for. And finally, everyone ideally would go to a local doctor or somebody regional that had EDS specific. So I apologize, I can't get too specific to any one particular person's problem, but I'll try to be as helpful as possible. So next question is septum repairs helpful? Septoplasty, everybody has a deviated septum to a certain extent. And septoplasty used to be one of the most abused operations by ENTs, where you could just look into somebody's nose. My slide deck just got disconnected. So now let me see. If somebody on the phone, can you guys hear me? If somebody could respond, if you could hear me.
Yeah, I can hear you. Is there a certain slide that you'd like for me to change to?
No. I wasn't. I was kind of off the slides, just answering all the questions at this point. So I'll try to re-log on to the website, but I'll keep answering these questions.
Okay.
For septoplasty, a septum repair. So it's something I tell people to be very wary about. The only patients who really would benefit from a septum repair are people who can't breathe well out of their nose. And it's better, frankly, if you tell me you can't breathe well out of one side of your nose, like, sure, I can't breathe well out of the left side of my nose, or the right side of my nose. It's always on my right side. And then you have a pretty severe septal deviation or turbinate hypertrophy that's blocking that side. If that's the case, then septoplasties can be helpful. In most cases, not most, I would say in several cases, I'm very wary. I think septoplasties are probably done too much in people. And, in patients who have EDS and we have slower healing and more hypertrophic healing than other people, it is a problem for us that, if we have surgery that's unnecessary, you might have healing problems after the surgery. So, okay, so sorry, now my whole computer just glitched. So I'm trying to log in. Can you, John? Can you tell me the HTML of our website again? The address to join into the conference center.
Do you have the link off of the announcement page? That would probably be the quickest way to do it.
Yeah, I
You're bringing up
don't have
EDS
that.
awareness.
Okay. Oh, yeah, I got it. Okay, sorry, it was the. Here we go.
Okay.
Okay, I'm sorry about that, guys. I am. I'm going to re-log in to enter the meeting again.
Okay.
So and then another aspect of our septum repair, the bigger issue is often your turbinates, which hypertrophy, and that is a very common problem. 20 million people in America have that allergic rhinitis. Treating your allergies with shots and allergy medicines is often a very good first line treatment, and then reducing those size of your turbinates can be very helpful. That's also, I take care of a problem where that's done too aggressively, and then that can be very debilitating. So it again just goes to the point that if you're choosing surgery, you guys have to be strong advocates. There's a variety of quality of surgeons and a variety of indications. So before you choose surgery, I would probably like to hear from 2 or 3 different surgeons the same opinion on why I need surgery. And if everyone is saying the same thing, then I would feel better. If I'm hearing a lot of discrepancy between the people I'm talking to, then I would be a little bit more wary. And so, that's frankly one of the things I hope to do is create a second opinion for surgery service where people just call us and send us their films and just get an honest second opinion before they consider having surgery. So, okay, so John, I've rejoined the meeting. It says, please wait, your meeting will start shortly, and there's no participants in my room anymore. So,
okay.
Maybe something is happening with my computer.
Okay. I can.
If not, I only had. I actually have my slide deck here, separate. Try to rejoin it. If not, I'll just tell you which slide to put the group on, and we can go that way. So let me finish the slides. I apologize, I can't see any more questions, but the slide was on chronic sinusitis. The therapies for chronic sinusitis. So after the acute rhinosinusitis, for people who have chronic sinusitis, there's unfortunately no FDA-approved therapies. Surgeons try a whole variety of things. Surgery is helpful for people. We don't really understand why. We think it changes the immune system in people. That really brings a lot of tissue. And frankly, what I think happens is there is a lot of blood that gets brought into the area of sinuses for surgery. And I think the addition of blood and bringing a lot of growth factors and regenerative factors from blood is what really helps people. It's a massive inflammatory response that helps clear all the bacteria and restore and rebuild a lot of tissue that leads to a lot of improvement. The vast majority of people with endoscopic sinus surgery, about 98%, have a long-term improvement. Several need repeat surgery, but most do extremely well with sinus surgery because I think it removes the pockets of infection that can cause a lot of problems. But and in children, like I said, and I agree with this, I think for children with EDS, I think I would err on the side of clearing adenoids from children quicker. And so having more aggressive tonsillectomies and adenoidectomies in children with EDS. So the theory of chronic sinusitis, this is a little bit unrelated, but it basically is a snowball. So once you start down the path, and if you get sick, you can continue to stay sick. And so and then these next slides on kind of current and future research as we go down. One is on a model we made of kind of the mucociliary blanket, and then several slides down, we can go through these quickly. One is a picture of this kind of web that our white blood cells use to trap all these bacteria, which is slide 20, and then slide 21 also showing that those bacteria groups have a lot of DNA. But in 2004, there was this great paper where people started to understand how our white blood cells migrate through our tissue to kill these films of bacteria. And that is what I think is impaired in patients with EDS. So what we've started, and then on slide 23 is this picture of of somebody with bad sinusitis. Like gray is soft tissue and swelling, so in between your eyes and your sinuses, all these black pockets should be huge black pockets, so all the gray you see in the sinuses are infection. And so one of the things that I'm doing for people with empty nose, but I think would be of very significant value to EDS patients, in fact, I'm going to probably try this on myself, is to draw blood and spin down your blood to enrich your platelets, which have a lot of growth factors in them, and then take this healthy collagen that has been synthesized and inject the collagen into our sinuses, and that will hopefully serve as a scaffold for new collagen growth, and the platelet-rich plasma will cause fibrocytes from our bloodstream to come and differentiate into fibroblasts and lay down more collagen. And like I said, the problem with most EDS patients is not that our collagen is deformed terribly, it's just that we don't have enough of a particular fiber, so they become tangled, because they don't have the right structure. So if we could enrich the amount of collagen that was being deposited, I think that would be helpful to people. So we're working on doing this. In slide 25 is a patient with atrophic rhinitis who these injections have been, and were really remarkable in improving their sinus health. Like on the top, you can see all this crusting and blood and infection, and then after 6 months, it healed very well. So with that, the last slide is my contact information, and I'm happy, like I said, to answer questions. From time to time, we try to respond to emails, but I think like this webinar is absolutely the best way to disseminate knowledge, and we're happy to see patients with EDS, and more importantly, I hope to become an active member of the society, and try to help people as much as I can, and also really try to advocate for EDS patients on a larger scale. But thank you very much for listening to me, and I hope to talk to you guys later.
Can you hear me okay?
Yep.
Okay. I was wondering if I had any additional questions, if you wanted me to try to read those to you.
Sure. Yeah, sure. That would be great.
Okay. And I wasn't quite sure maybe where you left off.
I apologize. I don't know why. I lost my screen all of a sudden. I think I was on, the last question was on this, is a septum repair helpful? And then I was kind of going from the top down, so any question after was if a septum repair helpful were the ones I didn't get to.
Oh, okay, I see where you are. Okay, there's a question that asks about nasal rinses. whether you see any reason that those would not work as well in a person with EDS, or any any difference in terms of that?
Yeah, that's a good question. The nasal rinses, I think, are very helpful for people who have had surgery because without that, you're kind of flooding your nose, which can't handle that much water, and most of it just goes down the back of your throat and kind of doesn't get to your sinuses. So people who have had surgery, nasal rinses are very helpful. If you haven't had sinus surgery, the NeilMed sinus rinses or the neti pods are probably too much fluid. Sinus, ocean nasal spray is helpful. Gargling with salt water is helpful. But I probably would not recommend using the sinus rinse or the neti pods in that they're just too much fluid to get into the areas that you need. But if you've had surgery and then you actually have access to those cavities, then those rinses are very helpful.
Okay. Not sure if this question was posed before. It says, who should I see if I have silent reflux?
If you have silent reflux, the best doctor to see is an ENT-trained laryngologist. So if there is a voice and swallowing department of an ENT department, typically in an academic medical center, that's probably who I would see. You can see both a speech pathologist and a laryngologist who's done an extra year of training specifically to deal with that problem.
Okay. It was recommended to my EDS daughter to have balloon sinuplasty. Is this a good procedure?
Yeah, now that makes me very worried. Balloon sinuplasty is the most lucrative procedure a doctor can do to make money, an ENT. I make sometimes $5,000 as high as $13,000 when I do a balloon operation for somebody. And so they are right now currently the most abused surgery in the field of ENT, with so many people being offered and recommended balloon sinuplasty, frankly, for reasons that I don't think they should have. So that's not to say that without knowing the specifics of any one particular patient, I can't comment on whether it's appropriate or not. But I would be very skeptical just, for anyone who has recommended balloon sinuplasty, and I would want several opinions before I would agree to having balloon sinuplasty. And in a lot of cases, it's a very minimal procedure that doesn't do much benefit. It requires all local anesthesia, so that might not work very well for an EDS patient, and often don't help patients unless they have a very specific problem for who the balloon can help, like in a revision operation. So, in fact, I'm going to be part of a big debate for the Triologic Society in San Diego in January, talking about that issue specifically.
Okay. One patient asks whether you address tinnitus in your practice.
I do. Tinnitus is, again, a difficult problem. I almost became an ear surgeon before I became a sinus surgeon because I loved cochlear implants so much. Restoring deafness in children, I think, is the best thing we have in medicine right now. So I learned a lot about tinnitus. For EDS, I would think that the tinnitus may be related to TMJ problems. People who have TMJ often get tinnitus and ear pain associated with that. So for somebody with EDS, that's the first thing I would investigate. I do take care of tinnitus, but there's not much we can do for tinnitus, honestly, that you can't learn from Googling tinnitus and the tinnitus retraining therapy and the noise machines. There's a study that melatonin might help. So being a sinus doctor, I don't see a lot of tinnitus patients, but, I do know a fair amount about tinnitus just as a random, background as to what I almost became an ear surgeon.
Okay. And do nasal sprays work as well in EDS patients as they might in others? This patient comments that hers always seems to wear off very quickly.
Yeah, I think nasal sprays should work well. Again, it's I'm generalizing it. I can't, it's hard to give advice for any particular patient. Typically, for people who have allergic rhinitis and those types of problems, then nasal steroids should be helpful. Steroids aren't great for people with EDS in general because steroids are not good for your joints and your collagen fibers, and so there's something that we should tend to err away from. If anything, we should be doing more of PRP types of therapies of platelet-rich plasma and collagen kind of injections as opposed to steroids, but steroids significantly reduce inflammation. So if you have a lot of inflammation, steroids sometimes give you a lot of relief, and they reduce swelling. So steroids are definitely a double-edged sword for people with EDS. But nasal steroids are not systemically delivered very much. So it can be hit or miss. A lot of people without EDS report the same thing, that nasal steroids don't work that well for them. So there could be a lot going on with somebody with nasal problems and requiring nasal steroids. Okay, great. Well, that was the last question. This other comment is something I'll just let you know of. This is from the patient who actually connected you and I together, and she comments that her husband traveled to have sinus surgery done by Dr. Duss this past summer, and he was just recently diagnosed with hypermobile EDS just this past week, and he wanted to comment that he didn't know that at the time of surgery, but his main complications were anesthesia-related, like taking longer to come out of it, nausea, headache, etc., and also more bleeding than typical, and they kept him overnight, whereas usually it's an outpatient procedure. But commented that she was very, very pleased with both the surgery and with the follow-up care with Dr. Dawson. She highly recommends you. Thank you very much. Yeah, that is a good point. In the same way, local anesthetics wouldn't, for some reason don't seem to work well. I think the recovery after anesthesia, it does make sense that would be longer. Yeah, and, now I have an N of 1 to say that that's the case. So, that is something to consider, that patients undergoing anesthesia with that EDS should be prepared for a longer recovery. And frankly, I'm going to work on trying to find an anesthesiologist who is aware of EDS, and if I can, that'll be an area that I try to research to see if I can find some links. And, hopefully our webpage, I'm going to try to create an EDS kind of webpage and meet several of the leaders who have EDS, talk to them about, I'm, hopefully going to go out to Washington and see the doctor who's got a diagnostic laboratory and really try to create a strong network so we get all these questions answered and have a very reputable, legitimate clearinghouse for high-quality information for people who have EDS. We're so thankful that we connected with you and sharing all of your knowledge, and I'm getting all kinds of comments here on the live attendees that they are just so appreciative of all the information that you've shared with them, and yeah, everybody is just really excited here. So thank you very much, and is there any last words that you would want to share with everybody? No, I really am just as honestly as excited as hopefully a lot of you guys are. I really am excited both to learn as a fellow sufferer and to be hopefully a very powerful force for, making sure that people are covered and treated appropriately and get to the right doctors that they need. So, yeah, I'm just as excited. So this has been great. Yeah, so thank you very much to the Crouch family as well for creating this network, which I'm really excited to be part of.
Great. Well, we appreciate Dr. Doss for this information. It's an area that we haven't addressed before, and we're always looking for interesting areas that are related to EDS, and sounds like since you've had experience with EDS, you can really relate to what our audience is dealing with, and we appreciate your information and the questions that you patiently went through. And I'd like to remind the group that there is another webinar yet this month, Dr. Byers, and that will be on December 17th. That'll be the last Wednesday that we'll do. In 2015, we will go to Tuesdays, the first and third Tuesdays. So please visit our website. We have a lot of good articles, and you can listen to the webinars from previous presenters. Tomorrow we will have the recording and the slides available for Dr. Doss' presentation. And I'd like to encourage you to, again, go to Body Support Store and look at the products that we sell. And that is the store that funds this free program. So please look and see if there's something. It's the holiday time. You might find something that you might like to buy for somebody for Christmas. So again, thank you for attending, and we appreciate you being here with us and all your questions. So I'd like to call it evening, so thank you very much.
Good evening.
Good night.
Good night.